It says it doesn't work, and then when I test it, it always works. Well, I got a skeleton crew again. All right, so the exam is finally at the point where I can hand it back. As you can see, it did not go well. As you can see, a generous curve covers a multitude of sins. I think I underestimated the difficulty of these topics more than a bit. So we'll just call that what it is, grace, and kind of move on from there. So we are discussing, we're in the process of discussing the treatment of diabetes mellitus. All right, Jacob, do the slides move?
They do not.
They do not. Of course they don't. They never do when they're supposed to. I need to talk to Cynthia Churchwell because this is really becoming annoying. Okay, now do they move?
Still no.
All right, and then we have to do this. God, this is annoying. All right, so let's remember type 1 diabetes mellitus refers to death of the beta cells. This is virtually always due to an autoimmune event. It is sometimes prompted by a previous infection. Sometimes it's due to some type of trauma. Sometimes it's frankly due to not anything obvious, but the onset is usually early. So people who first get diagnosed as type 1 diabetics are usually young. Occasionally you get people in their 30s, but it's not very common. You do sometimes get people who've been in severe accidents, who get blows to the midsection, and that blow to the midsection causes the pancreas to liberate all those enzymes, and then the pancreas starts to digest itself. Under those conditions, someone can become a type 1 diabetic. That's not at all common. You also see type 1 diabetes developing in people with cystic fibrosis because the pancreas gets clogged with very thick mucus, and then the pancreas will end up digesting itself. So that's called cystic fibrosis associated diabetes mellitus. People with cystic fibrosis usually also have to take oral pancreatic enzymes to be able to digest their food because their pancreas just kind of packs it up. Type 2, diabetes mellitus, usually associated with obesity, and is usually a disease that occurs later in life. Albeit we're seeing it earlier and earlier as obesity occurs earlier and earlier. Very strong genetic component to this disease, also rather strong genetic component to this disease as well. This will also tend to run in families. So both of them have strong genetic factors that lead to them. So with this one, you have insulin insufficiency. And with this one, you have insulin resistance. In elderly people, you sometimes get asymptomatic diabetes where their blood sugar gets higher than it should. And yes, it should be watched, but you don't have to treat that super aggressively sometimes. The increased blood sugar can be because they're on other medicines that may increase the blood sugar. Or it just may be the pancreas starts to eventually give up the ghost. Some of you may have had breeds of dogs that will start to become diabetic later in life. You see this in inbred golden retrievers. You'll see it. You also see it in huskies. All of a sudden they start drinking a lot of water and not having nearly as much energy as they used to have, that sort of thing. That's not that uncommon also in elderly people. So whether it's type 1 or type 2 diabetes, you see the increased amount of glucose in the bloodstream. That increased amount of glucose in the bloodstream is a hallmark of the disease, hyperglycemia. And because cells cannot take up glucose and use it as effectively, the body now needs to turn to ketone bodies. So increased ketone secretion by the kidney means that the kidney has to secrete a lot more water. That will cause increased urination, polyuria. With increased urination, increased water loss, you have increased thirst. That's polydipsia. And because cells can't take up glucose, they're starved. So people are always hungry, and those are the 3 Ps that are the main triad of symptoms in people with diabetes, type 1 or type 2. Polyuria, polydipsia, polyphagia. In addition, people will have fatigue and dry skin, drier than normal, and blurred vision. Now, the long-term complications of diabetes can be pretty profound. So one of the first places where you see the effects of diabetes is in the blood vessels. Paradoxically, diabetes thickens blood vessels. But even though it thickens them, the blood vessels are leaky. So the blood vessels don't work very well, and because they leak, you tend to get edema and inflammation throughout the vasculature. Thickened blood vessels also don't do a very good job in the capillary beds of gas exchange. This has profound effects for 4 specific organs, the first being the kidney. So diabetic nephropathy is a type of nephrotic syndrome where you have destruction of the glomerular Bowman capsule border. You're going to have a lot of protein in the urine. You're also going to lose a lot of electrolytes and things like that. Eventually, that border gets scarred up, and now urine production goes way down. And now the patient will need either a kidney transplant or dialysis. The heart as well, because those coronary arteries are going to get scarred over and thickened and leaky, your delivery of blood to the heart will be very poor. Inflammation in the heart will also tend to be inimical to its activity. So that is diabetic cardiovascular, cardiomyopathy, diabetic cardiomyopathy, increase the risk of heart attacks. Diabetic neuropathy is felt most acutely in the feet. That's where you feel it first. You feel it in the toes, then it tends to work its way up towards the ankles and then up towards the knee and so on and so forth. People can have severe injuries on their feet and not know it. If you deal with a diabetic patient, something you should always do first is check their feet, make sure there aren't any sores. Those sores can become gangrenous and it will increase the risk of amputation. Diabetes is still the #1 reason for amputations in the United States. The way you test for neuropathy, if you've had any classes with Mitch, he's probably told you about the tuning fork test, where you take the tuning fork, it should be 128 tuning fork, and you give it a whack on your hand. If you whack it on your knee, it tends to hurt, so whack it on the palm of your hand. You put the tuning fork on the toe right underneath the nail, and their Pacinian corpuscles should be able to feel the vibration. They can't feel the vibration. You then work from the toe onto the instep and then the ankle, and then until they can feel it. So you get the so-called sock and glove neuropathy. You feel the sock first and then the glove later. That is due to damage to peripheral nerves due to excessive amounts of sugar. So checking feet, the feet of the patient, keeping the feet clean, making sure any sores are properly covered with bandages or something like that. Those of you who've done a lot of aerobic athletics, if you run or play tennis or play soccer, your feet may tend to be a bit dead anyway from all the pounding, but this is orders of magnitude worse. So it's really important that you keep the feet clean and be checking them. Fourthly, diabetic retinopathy. Because the cells of the retina can get starved for sugar, the blood vessels will start to branch and go throughout the retina. Wherever those blood vessels go, it's going to displace photoreceptor cells. So your vision gets dimmer and dimmer and dimmer. There are ways to belay this. There are injections that you can put into the retina to belay this, but this is a problem and it can lead essentially to an ischemic retina that can cause blindness. So these are all long-term complications of diabetes. I think you'll admit having to go on dialysis, having heart attacks, having blindness and amputations all equal a really bad day. So this can be belayed by careful control of blood sugar. But if you don't control your blood sugar, this is what you're looking at. I have a friend, he's one of the directors of quizzing at the West Branch Free Methodist Church, Mike. does not control his diabetes, and Mike has no feeling in his feet now. And we have the conversation every time I see him, you know, Mike, you might want to deal with that. Some people who don't take care of their feet, they kind of tend to lose them. Oh, you sound like my wife. Yeah, and maybe more people should talk to you this way because maybe you'll do something about it. So how do we define hyperglycemia? So if your fasting blood sugar is above 126 milligrams per deciliter, so that's after a 12-hour fast. If your blood sugar is above 125, or if on an casual blood glucose check, you have a blood glucose level over 200 mg per deciliter. Or if on an oral glucose tolerance test, you reach over 200. Those are usually reasons to say you're hyperglycemic. The other issue will be, do you have symptoms? Because some people may go above 200 on an oral glucose tolerance test, but they have no symptoms, in which case you might be at risk for it, in which case you'll be watched. So the American Diabetic Association categories for a fasting blood glucose, anything above below 100 is normal. Anything at 100 or above is impaired. So if it's above 100 but less than 126, that's impaired. You're in the pre-diabetes range. Many physicians will say, if you're below 104, you're probably fine. But if your fasting blood glucose is above 126, you're diabetic. Who should be screened for diabetes? Anybody over 45. When they go in for a physical and they get the blood drawn, the blood glucose will be one of the things that they will have checked. If anyone is younger than 45 years of age, but they're obese, they have a first-degree relative with diabetes mellitus, they're a member of a high-risk ethnic group. High-risk ethnic groups would include Latin Americans, American Indians, African Americans. Those groups tend to have more diabetes than other groups. They're generally at higher risk. Also, any woman who has had a history of gestational diabetes, this is diabetes during pregnancy, or if she gave birth to a baby bigger than 9 pounds, oh, that's big. Toddler at birth. Give birth to a bowling ball. Or if they have hypertension, then they should be screened. Then you need to be screened. The baby, usually if you are diabetic during those last weeks, the baby will grow as fast as it can receive nutrients from the mom. If the mother is diabetic, it keeps taking and taking and taking and growing and growing and growing. So diabetic mothers will tend to have big babies. That's why some diabetic mothers, the doctor will just schedule a C-section. Because giving birth to a 12-pound baby, it's cruel and unusual punishment. Are we in agreement on that one?
Yeah.
Yes. So some diabetic moms will really want to give birth vaginally, and based on the size of the baby, the health of the baby, and the health of the mother, the doctor may play ball with you. Hospitals, unfortunately, nowadays in this country, one, if you've had a C-section already, your risk of uterine rupture is greater. It's not hugely greater after one C-section, but the risk is increased enough as to where the insurance of the hospital says you have to give that woman a C-section. which I find highly troubling, that insurance is dictating to doctors how to practice medicine. But that's just the reality of the world we live in. So some mothers who've had C-sections will actually opt for midwives and home birth. That way the doctor's not forcing them to get another C-section. And my wife is Dutch. All her Dutch relatives, except for the ones who had twins, had home births. Home births are very common in Holland. Plus, having a baby in a hospital is very expensive in Holland. So that's the reason why home births are quite common. In England, home births are also relatively common. So you have, in England, midwives do most of the birthing unless the birthing is high risk. Then you'll have an OB who will do help with the birthing, but it's all done by midwives. And you'll have two midwives, one who is a fully licensed midwife, another who's a trainee. You have to assist in 40 births before you get your license as a fully licensed midwife. So these are nurses. They're like our labor and delivery nurses here. So once you become a nurse, you do midwifery, and the midwifery is a specialty of the nursing. And when my oldest daughter was born at Royal Sussex Hospital, Jane was our fully licensed midwife, and a girl whose name was, get this, Lulu. Rachel was her 20th. So Rachel was her midterm before she became a fully licensed midwife. The midwives do a good job. And I don't like the stereotype, but it's my experience. Virtually every midwife you meet in England is a woman. Most labor and delivery nurses you see in the States are women. I just think, call me sexist if you want, I don't care. I just think women are more interested in that subject than men are. Okay, nobody's throwing anything at me, so I'm guessing you guys agree with me on that one. It's amazing what you can call sexist for these days. So once again, to rehearse, type 1, insulin deficient, typically young, typically lean. Treatment for both types of diabetes, diet and exercise. Must. Exercise increases insulin sensitivity. Type 1 diabetics must inject themselves with insulin. Must. No two ways about it. No way, no how, They must inject themselves with insulin. Diet is huge because they're going to have to replace carbs with proteins and fats and things like that. They're going to have to count their carbs. And they have to give themselves insulin that is commensurate with how many carbs they are eating. And then type 2 diabetics, unless they are older and their beta cells are failing, will usually take medicines that increase their insulin sensitivity or increase insulin output by the beta cells. Diet and exercise are also huge for type 2 diabetics. In fact, there are some type 2 diabetics who can control their diabetes with diet and exercise. Not all, but some. And diet and exercise will always help a type 2 diabetic. And those of you who are in your education, you wish to be health coaches, this is a growing field since we have a growing epidemic of diabetes in this country, working with diabetic patients to help them lose weight, get in shape, keep their muscle tone. This is definitely a really big field growing field for people who want to be health coaches. Type 1 diabetics. We already talked about how they have to replace carbs with proteins. They also can't skip meals. Skipping meals is a bad idea. You want to try to take the variations in blood glucose and try to narrow them as much as possible. With constant glucose monitors, CGMs, that's much more doable these days than it used to be. Now the CGMs are actually in line with your phone. So you get programs on your phone that will constantly show you a constant readout of your blood sugar. Insulin is the major anabolic hormone of your body. So for kids, you have to make sure you're maintaining normal growth and development. For type 2 diabetics, you have to keep their blood lipids down, because if their blood lipids are not in a proper range, they're at higher risk for atherosclerosis because of the increased inflammation in their blood vessels. They need to achieve a healthy weight and keep it. You should recommend they visit a dietitian. You also have to watch the types of foods that are consumed. So peanuts are better for type 2 diabetic than peanut M&Ms, because peanut M&Ms have a lot of carbs. So peanuts have peanut oil and peanut proteins. So you have to make sure that the types of foods that you consume are ones that aren't going to spike your blood sugar. So we'll talk about the drugs for type 2 diabetes, and then we'll get into the insulins, and that's the order in which we'll do this. So your medications for type 2 diabetes come in 6 categories. So there are the so-called insulin secretagogues. Insulin secretagogues increase the amount of insulin the beta cells make. There are 2 classes of drugs, sulfonylureas and meglitinides. The meglitinides have a shorter half-life than the sulfonylureas. They're insulin sensitizers that sensitize peripheral tissues to insulin. This includes the biguanides. There's one biguanide, metformin. Metformin is the mainstay of type 2 diabetes treatment. Then there are the thiazolidinediones. Oh goodness, who named these things? We're going to call those the TZDs, because thiazolidinedione makes my tongue hurt. So TZDs. Then there are those that decrease glucose absorption. Those are the alpha glucosidases. Those take complex carbs, delay their degradation, so they delay glucose absorption. They cause a more modest increase in blood glucose. And then there are the dipeptidyl peptidase 4 inhibitors. Dipeptidyl peptidase 4 degrades incretins. And then finally, the incretin mimics. These are ones that bind the glucagon-like peptide 1 receptor. So these are glucagon-like peptide 1 receptor agonists. And then the sodium glucose transporter 2 inhibitors that work in the kidneys. Those are the newest of the anti-diabetic drugs. Very good. Let me pause right here, see if there's any questions. No questions? Let's dive right in then. Let's talk about the sulfonylureas. The sulfonylureas used to be a really big group of drugs. Competition for the best drugs made it so that there are only 3 drugs that were prescribed. So these are the only 3 that are made now, which means you have fewer drugs to memorize, which is always good. So there's glipizide, glyburide, and glimepiride. Those are the 3 sulfonylureas. Notice that glipizide comes in an immediate release and in an extended release form. So glucotrol and glucotrol XL. However, this drug does come in generic and the generic version is very inexpensive. Generic glipizide, a month supply is $2.40. Pretty inexpensive. The extended release generic month supply is $5. Very, very affordable. That's one of the upsides of the sulfonylureas. They're very cheap, very affordable. These drugs, because they increase insulin production by the beta cells, and since insulin induces fat synthesis, they can cause weight gain. This is problematic if you're diabetic and you want to lose weight. You're taking drugs to control your blood sugar, but those drugs cause you to gain weight. That's a drag. The other thing these drugs can do is they can cause your blood sugar to go too low. They can cause hypoglycemia. Glyburide has a higher tendency to cause hypoglycemia than the others. For some people, these drugs can cause stomach upset. However, the extended release forms tend to prevent that. There are also some risks with your skin. Your tendency to get sunburn goes up. This is particularly a problem in people of a lighter hue. So if we look around the room, who in this room would have the highest risk? Yes, Kennedy, it's you. So depending on their skin hue, Maddie, if Kennedy's your patient, you're going to exhort her to wear sunscreen. And Kennedy's going to ask you, well, what brand of sunscreen is the best brand? Consumer Reports has a very good article on some sunscreen brands. Look it up. Have at the ready a list of sunscreen brands that are the best that you can say, oh, here are the 5 best. They're not that expensive and they'll protect you. Just make sure you wear it every time you go out gardening or you go swimming or you go to the beach, and try to not be so pale and what have you. It's genetics. Yeah, well. And that's something that as a clinician will be of great help to patients. Occasionally, people will get rashes on sulfonylureas. Again, low dose and extended release forms tend to make that not very common, but it has been reported. Also, if the GI issues are a problem, taking the drugs with food tends to belay that problem. So sulfonylureas do cause long-term reduction in micro and macrovascular complications. They also reduce the tendency to have protein in the urine. So they delay damage in the kidney. The meglitinides, they include 2 different drugs, repaglinide and nitaglinide. Repaglinide and nitaglinide. These drugs work essentially the same way as sulfonylureas. The difference is that these drugs have short durations of activity. So you take them with food, they work as you're absorbing the glucose. After you've absorbed the glucose, they stop working. And so they are quite well tolerated consequently. They can also cause weight gain. They can also cause hypoglycemia, but this problem is especially acute in people with renal impairment. So these drugs must be adjusted for people's kidney function. These drugs are also relatively inexpensive. Oh, let me give you an idea here. Oh, they're here somewhere. Oh, here they are. Both of these drugs are in generic. A month's supply of repaglinide is $20. And you take it 3 times a day. So that's 30 times 3, that's 90 pills. $20 for 90 pills. It's not that expensive. Netaglinide is more expensive. For a month's supply, that one is about $40. So that one's a right bit more expensive. Here's a little primer on how these drugs work. So let's talk a bit about some beta cell physiology. So here's your beta cell in the pancreas. There is a facilitated diffusion transporter called the GLUT2 transporter. This will take up glucose according to the concentration disparity outside the cell versus the concentration inside the cell. So if you get more glucose in the blood because you have eaten, you'll have more glucose coming into the cell. More glucose coming into the cell causes the glucose to be metabolized by glycolysis. Glycolysis produces ATP. Now over here, we have a sodium-potassium antiporter that exchanges sodium for potassium. You also have a potassium channel. This potassium channel causes potassium essentially to leak from the cell. That way you don't OD on too much potassium. ATP, however, can bind to this potassium internal resistance channel, KIR channel, and inhibit it. That causes potassium to build up in the cell. That causes depolarization of the membrane. Depolarization of the membrane is going to open this voltage-gated calcium channel. Calcium, therefore, will come in. Calcium is going to cause these vesicles laden with insulin to fuse with the membrane and release the insulin into the bloodstream. So increased glucose coming into the cell closes the potassium channel, depolarizes the membrane, opens the calcium channel. Calcium comes into the cell, causing the insulin-laden vesicles, which are right underneath the membrane, to fuse with the plasma membrane and dump the insulin into the extracellular space, which will be taken up by the bloodstream and what have you. Sulfonylureas and meglitinides bind to the KIR and greatly increase its sensitivity for ATP. Therefore, a little bit of ATP causes this channel to close very tightly, causing extensive depolarization, extensive influx of calcium, and even greater release of insulin from the beta cell. That's how these drugs work. What are the signs of hypoglycemia? So hypoglycemia is classified as either mild, moderate, or severe. You are at about 60 mg per deciliter or lower. You will start to sweat, and the patient will look pretty pale. So sweating and pallor. Also, increased heart rate, tachycardia. the patient will usually start to have some shakiness and hunger. There'll also be some irritability. The other thing they'll start to get is they'll start to get tingling in their fingers, their toes, and in their lips. I had a diabetic roommate when I was in graduate school. Greg used to always do this. That was a sign he was starting to get some paresthesia in his extremities. I'm like, Greg, do you need some more juice? And Greg would say, I think it's going away. Yeah, I need some juice. So should this happen, usually a half a cup of fruit juice or some raisins, glass of soda or a glass of milk usually will raise the blood sugar back to its normal levels. Many diabetics will have glucose tablets. They can pop a glucose tablet and suck on it. And the glucose will go, especially if they put it under their tongue, gets absorbed quite quickly. They'll also have this stuff called a goop, glucose goop. It's in a toothpaste looking tube. It's brownish. It's disgusting, but it's essentially glucose goop. Drop of honey, you do the same thing as well. And that's a bit more tasty than their glucose goop. If their blood sugar falls below 40, now they have moderate hypoglycemia and they will have the symptoms that they had for mild, but now they'll be unable to properly concentrate. They'll have confusion and slurred speech, poor balance, irrational behavior, slowed reaction time, blurred vision, and extreme fatigue. Best antidote for this is a nice tall glass of juice. The patient should wait 30 minutes before they resume activity. If their blood sugar is 20 or below, they have severe hypoglycemia. You'll have all the other symptoms plus disoriented behavior, loss of consciousness that will be hard to arouse. They may then go into coma, and if it's not fixed, they may die. What they need at this point is glucagon. All diabetics, type 1 diabetics, will carry with them a container that is orange, like this, or red. And in it, there will be a glucagon shot. And you can see it's ready to go. You simply, this is already filled. You take it out. You inject this into here. This is a powder. So you put this into here, you put it in there, shake it up, withdraw it, and you then insert it into the biggest muscle you can find, which is usually the quadricep. Just put it in, and usually they'll come out quickly. Do not give them insulin. There have been cases where people passed out and people wanting to do the right thing have given them insulin. So good intentions plus ignorance sometimes equals catastrophe. Kind of like our US government, where we take excess food and we dump it on South American markets and we crash their agricultural markets. We keep doing that, even though you think we learn our lesson, but our government doesn't seem to learn from history. So you learn from history, okay? If that gets to be the case, they need glucagon. And they'll have a pouch, it's in a container that's red. And there are other formulations of glucagon, powders, things like that you put up the nose. We'll talk about those, but glucagon is your drug of choice. And Jacob, in case you didn't see it, here's the glucagon container. It's red, as you can see, like this. And contains a syringe with liquid. You put that into the vial here, shake it, withdraw it, and then put it into the biggest muscle you can find. Oh, and on the inside of this, there are even pictured instructions. Can't go wrong, truly, can't go wrong. Also, I don't know if this is the case in Michigan, but in California, there are what are called Good Samaritan laws. So if you say someone passes out, you give them their glucagon, they wake up, but they say, oh, they wrecked my leg. I can't run marathons anymore because they wrecked my leg. Yeah, but they saved your life. You're covered by what are called Good Samaritan laws. So people doing CPR, if you happen to break someone's rib, you're covered because of Good Samaritan laws. Now, if you don't know what you're doing, you're not certified, then you could be in trouble. But if you're certified CPR and you end up breaking a rib, I don't know. Does anyone know what the case is in Michigan for that?
I was told that you're covered.
So in Michigan, it's the same. Good Samaritan laws cover you. Okay. Then I think you're covered as well in Michigan. Now, if you're a physician and you screw up, that's another story. But if you're not a trained health professional and you do something to help someone and it ends up causing some damage, they can't turn around and sue you because they have a broken rib or because they have a sore leg or something like that because you saved their life. Sulfonylurea, emphasize, they're not insulin. They're also not a substitute for diet and exercise. Make sure the patient knows the name of the drug, dosage of the drug, and the side effects. Make sure they know the signs of hypoglycemia and know how to treat them. Ditto for the meglitinides. Very good. Any questions about sulfonylureas, guanides? All right, let's talk about the all-important metformin. For years, nobody knew how metformin worked. People just knew that it worked. And then a paper came out in 2012 from the big diabetes lab in Princeton. And they were able to show that metformin works in the liver, and it works on an enzyme called AMP-dependent protein kinase. It binds to that kinase and activates it. Metformin is oral, does not stimulate insulin secretion. And on insulin, you lose weight. I'm sorry, on metformin, you lose weight. That's one of the beauties of metformin. Metformin can also be combined with sulfonylureas. And if you combine it with sulfonylureas, you mitigate the weight gain effects of sulfonylureas. So it plays well with other drugs as well. Metformin is inexpensive. The response you get is durable. It lowers weight, does not cause hypoglycemia, and it reduces the risk of long-term side effects. How does it work? By activating the AMP-dependent protein kinase in the liver. That particular protein kinase regulates gluconeogenesis in the liver, so it shuts off glucose production by the liver. It sensitizes peripheral tissues to insulin, so it increases peripheral insulin sensitivity. It also increases the utilization of glucose by the liver, thereby lowering blood glucose levels. The most common side effects of metformin are upset stomach. However, the extended release forms mitigate that. You can also take the drug with food. Diarrhea tends to be frequent, but if you start at low doses and titrate up slowly, that tends to not be a problem then. It can also cause a metallic taste in the mouth. I have been told by several endocrinologists, recommend sugarless chewing gum to the patient, or sugarless lifesavers that are mint or peppermint, and that will tend to mitigate the metallic taste in the mouth. Can also cause B12, vitamin B12 deficiency. So vitamin B12 supplementation might be necessary. Remember, one of the side effects of vitamin B12 deficiency is megaloblastic anemia. To prevent megaloblastic anemia, take supplemental vitamin B12. There are sublingual vitamin B12 vitamins you can get from Celebrate Vitamins. You put them under your tongue, they dissolve, and that helps with your B12 levels. Most severe side effect is lactic acidosis. Lactic acidosis is not at all common. It's particularly seen in people with decreased renal function because it inhibits gluconeogenesis. Lactic acid production by the muscles is usually dealt with by the liver. The liver takes lactic acid and uses it for gluconeogenesis. Without gluconeogenesis, lactic acid builds up. Your kidney will have to excrete it, but if your kidney doesn't excrete it, it will build up and cause acidosis. So lactic acid acidosis can be potentially life-threatening. It's not common, but because of this, you don't give it to people with a history of renal, hepatic, or cardiac disease. Also, if any of you end up working in the intensive care, if you give any sort of contrast dye that contains iodine, you must withdraw the metformin and then wait 48 hours after giving the dye. The kidney will compete, in the kidney, the dye will compete with metformin for excretion. Therefore, metformin levels will be raised and increased risk of lactic acidosis. So you wait 48 hours before starting metformin if they've been given any sort of iodinated contrast dye that are used for MRIs or something like that. That's more important if you're a nursing student, but it's also a feature of metformin. Any questions about metformin? Metformin is oral, and it comes in tablets that are scored, so you can cut them in half or something like that. It's taken, the extended release forms you take once a day. The immediate release forms you take twice or 3 times a day. Generic metformin, immediate release, a month supply is $3.60. Month supply of the generic extended release is $8. Very inexpensive drug. Alpha glucosidase inhibitors include acarbose and miglatol. Acarbose and miglatol. These are inhibitors of the brush border enzymes that degrade poly and oligosaccharides. They delay glucose absorption, and instead of getting a spike of glucose, you get a smoother increase of glucose, which if you eat your dinner and then go for a walk, that can control your blood sugar quite effectively. Their effect on blood glucose is modest. Therefore, these drugs are never used as a monotherapy. They are used as an add-on. The biggest downsides of these drugs is that those polysaccharides and oligosaccharides are now fermented by the bacteria in your GI tract. Therefore, they can cause a good deal of flatulence. That flatulence can cause gas pains, abdominal pain in some people, and it can cause diarrhea in some people as well. You don't give this drug if people are known to be hypersensitive to the drug, which does happen. You also don't give it in people who have cirrhosis of the liver or have diabetic ketoacidosis. You don't give it to people with inflammatory bowel disease. It'll make their inflammatory bowel disease a lot worse, particularly in people with Crohn's disease. You don't give it to people with chronic intestinal diseases. People with short bowel syndrome, something like that. It's contraindicated. Also, don't give it to people with renal insufficiency. All right, let's talk TZDs. So there are two of the TZDs. There's pioglitazone, which is called Actos, pioglitazone. And then there's rosaglitazone. These are very interesting drugs, frankly, when it comes to the way they work. These have a low risk of causing hypoglycemia. They do cause durable reductions in blood glucose levels. These drugs bind to a transcription factor called PPAR gamma. PPAR gamma stands for proliferating peroxisomal activation receptor. That's why we call it PPAR, because that's kind of a mouthful. Peroxisome proliferator activating receptor, PPAR. When they bind to PPAR gamma, they activate the genes that are targeted by PPAR gamma. Those genes are involved with the metabolism of fat and the metabolism of glucose. Therefore, they will increase peripheral glucose sensitivity. They'll also increase fat metabolism. Because they increase glucose sensitivity, you can gain weight on these drugs. Also, they can increase LDL levels. That's a downside of these drugs. Now, there were reports that both of these drugs were associated with an increased risk of heart failure because they do tend to cause fluid retention. Further randomized controlled trials have called this into question. Therefore, the FDA removed the black box warnings on these drugs that were placed in 2010. As of 2019, those restrictions have been removed. So these drugs are probably safer than were originally thought. You do get an increased risk of fractures if you're on these drugs for a long period of time. They can be combined with other drugs as well. And it is 8:45. That means Mickey tells us it's time to knock off. So this is our last full week of instruction. If you want to hand in any other assignments, or if you want to, if there's an extra focus that you want to do, you haven't handed in yet, or anything else you want to hand in, you must hand it in by the end of this week. I will not accept it next week. Also, please continue to look at your Blackboard grades. If there are any holes, please let me know, and I will continue to do battle with Blackboard in the realm of grade entry. I did some more battle this weekend. There's an old song, I fought the law and the law won. It kind of keeps running around in my head, but I'm hard at it. So if there are any grades that weren't submitted, please let me know. And beyond that, study hard and get ready for the final. Stuff is not due by May 9th.
Like it's due, like I just Friday and that one next Monday.
Interview with a pharmacist is due next Monday. Yeah, but extra credits and stuff like that due by Friday. And Bree, you sent me an email. Why don't we have a short chat about what you about? Okay. All right.